Yeah, now, okay, let's get down to serious. Okay, here you go. Here you go. Okay, lah. Lie. Take. One more person? Yeah, okay. Yeah. Lynette, what do you have in your hand? A cup. A can? Okay, I got one more. Yeah.
Oh, okay.
What do you have? What do you have?
Oh, bag.
A bag, yeah. One word for all of these. Only one word. Wonderful. Who said container? Nice. These are all containers. Correct, right? Yeah. So if you imagine, right, how did the container start in caveman times, right? Most likely somebody staying in the cave, right? I'm thirsty. The river is outside, but there are predators. So I'm watching out. No animal nearby. But then, you know, my sister died the last time she went to drink. She was eaten up. It's like, okay. Then I quickly come back, right? That would be what I do. And then it's like, go back. And then, inside the cave, I'm looking at myself and saying, this is a container. I got an idea. Why don't I make 2 hands out of clay? I go outside, I collect water. Now I can get water for everyone in the family. First container ever made. Great invention. Now we have no end of containers, right? Yeah. The same cave person made clay hands, but now she put bobby pins inside. Now she put jewelry inside. Yeah? Containers. So when Nav asked me, very broad structure, talk about yourself, talk about your work, and talk about its impact. It's like, I don't know where to start. So I'm going to contain this. Okay? And I'm going to squeeze it down a little bit. Okay? To say, containers are great. So he calls me Dr. Wong. I told him before, call me Sweet Fan. Well, when you call me Dr. Wong, that's a container. That's a container because that means you're looking at my expertise. Yeah, and I can do a lot of this medical stuff, right? But, you know this design stuff? The hospital doesn't like it. You know, because she's running outside, doing all this design stuff, what is she doing? They can't understand. But when I am Sweet Fun, I can do anything and everything. Please call me Sweet Fun. Yeah. So containers are great. If you want to contain something, they can be cages. Yeah. So I thought I'll talk about containers, but then it won't last 1 hour. Yeah. So, okay. So somebody, yes, you said rectangle, right? Interesting, right? She said rectangle. Yours? Box with compartment. Honestly, 2 of them are boxes. Right? Just one with compartment and one with not. So, that one is what is called a hospital. Health system. This one is called community. Why? You know, in the hospital, right, we have people coming with heart problem, brain problem, food problem, eye problem, social problem, yeah? And then what we do, we put them in the nice boxes. And then we work perfectly, expertly in silos. So I got heart problem, then, sorry, I got confused. They're going to refer me to the geriatrician. And the geriatrician says, no, she's not confused, she's got a stroke. Then I go to neurologist. And they all do their work perfectly well, but within the compartments, yeah? And they got a system, protocols to move people around in as few steps as possible, and hopefully solving at every stop that you make trundling down the hospital corridor, it is a horrible experience because not only you see the lights going by, it's this on your head, right? It is a very uncomfortable journey. Yeah. The difference, this one. If I give you a lot of things, what are you going to do? You just throw everything in lah. Capalang lah, right? When you want to take out the necklace, it got caught on the biscuit or safety pin. When you try to take out the safety pin, oops, the ring came out with it. It's messy, right? Technical terms of messy, complex. So we think hospitals are complex systems. They are. And patients actually find a lot of difficulty navigating the hospital. And Lynette has shown how we try to reduce that complexity, to move it away from system back to person-centered care. It is a real effort. In the community, you have no choice but to deal with the complexity head-on. You want to deal with health, somebody will tell you, I'm not interested, I got no job, so I'm not going to buy the medicines that you asked me to buy. And yeah, I know I'm going to come back 3 years later with the amputation, but what are you going to do about it? Yeah, so I decided not to work inside the hospital, go out and do what we call forward defense, right? So Singapore does this very well, by the way. So as a country, we are very small, and we are very vulnerable because we are also very porous. We have a great travel system, right? People fly in, people fly out. People land in Singapore as a stop before they go elsewhere. So guess what? Infectious diseases fly in, fly out. In fact, rats also fly in, fly out. Cockroaches also fly. Mosquitoes also fly in, fly out. Correct? Yeah. So what do we actually do? We actually ask our experts to go to the other countries nearby in Asia, train their people to improve their health so that when they fly in and fly out, there are fewer sick people that come through us. Yeah, that's forward defense. So in addition, the bonus is we get good relationships with our neighbors. Yeah, so doing good does make us do well. It's not foolproof, but it's a good thing to do. Yeah. So forward defense is going to the community and talking about reimagining health, not healthcare. So I'm so glad when Neff he put there reimagining healthcare. Then after that he put a slash in between health and care. Right? Because I'm going to ask Clara, have you ever asked somebody like, how's your health? Yeah, you have, right? Good, nice. Ask your brother. And you ask your brother, how's your health care? Like, what kind of question is that, right? Nobody ever asks, how's your health care? Maybe if you had undergone care, people will ask, how is the care that is rendered to you? But nobody ever asks, how is your health care? But people usually ask, how is it? So, complete the sentence. My health is in the hands of dash. Any offers? Nice. Okay. Anybody wants to say my health is in the hands of my doctor? The system, the government. Nice. Nice. Okay. Yeah. The question is wrong. Right? The question is wrong. Because yes, my health or my return to health when I'm sick or injured is in the hands of a doctor or a nurse. But when I'm well, do I think about hospital? No. Do I think about health at all? No, some of us maybe we buy vitamins. Yeah, but we won't spend a dollar extra on health. Right? Hey? Yeah, okay, yeah. This guy is smart. Yeah, okay, yeah, smart, James, smart. Yeah, yeah. So just be very clear. Our health is in our own hands. Because what is health? Health is not about being sick. Health is about the everyday decisions that I make for myself. What I eat, whether I move or exercise, whether I go out or stay at home, right, and not have friends. Health is about all the decisions we make for ourselves. So our health is in our hands. When we look at health, I have a picture here. Am I? Okay, I think I've talked, I've talked enough about myself. I better tell you what I do first. Sorry. 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 Okay. Yeah. So this is what I do. Sorry. Yeah. Just must follow his what, right? So I really created what I call community care system. I wouldn't even say it's a community health system, but you can call it a community health system. But this is one Singapore model that's just in the north. That's just in what I call Yishun Health. Okay, that's where I work at the Kutikpot Hospital, which is the main acute hospital in that region called Yishun in Sembawang. We do have a community hospital, an ambulatory medical center, and what is this thing called community notes bracket 39? We have 39 notes in the whole of Yishun in Sembawang where we actually go there, be present, and people can come without referral, without payment, without appointment, just to see if they can ask a question to the nurse. Yeah? Okay. So, but why did we even start going to community care, right? It's like, actually it was a national problem. It's the fault of the nation. Yeah, we had aging population. That time the population was increasing in size, and worse, we had an aging population. And you know, as we age, right, we're going to have more chronic disease. Chronic disease is going to be more advanced. We have multiple chronic diseases. Like a national problem became a local problem. So we opened our hospital in 2010, okay? And June 2010, we opened. Look at that. A good occupancy rate is 80%. So we were okay. That's like barely 2 months. But we hit 100% within 8 to 10 months. And that's no good. Means we cannot turn over. Yeah. And then we thought, it's got to stop, right? It's got to stop, right? No, it seems like they want to try our new beds or our new blankets or something, but they just kept coming. And so we were wondering how to do anything about this. So the rest of the hospital just sprang into action, right? Create more beds, discharge people faster, do things, right? We went and we saw, oh, there are lots of people lining up to go into the hospital. But there's this group of people, right? They're coming back around. They go home, they come back, they go home, they come back. We call them frequent flyers. Yeah, and we thought, okay, we're not doing something right. There's something wrong with our care. Yeah. So we said we had to innovate. And the impetus was that we have to reimagine the care model while everybody is working very hard to manage the load, right? So we said we got to start having, instead of a doctor-centric model, a patient-centric model. We've got to shift the care model from a medical model to a health and social model. In fact, we call it a biopsychosocial model. And we've got to shift the site of care from hospital to community. And some of the new approaches, we said, we stop asking our very diagnostic question. This is what we're trained to do. What's the matter with you? This is our diagnostic process, right? And we've got to shift to what matters to you. And it is very important to ask this question because honestly, we miss the mark when we try to do diagnosis. I'll tell you a story of a 33-year-old man. He had diabetes since the age of 13, and he had actually very good diabetes control for when he was young, okay? And then it grew average, and then suddenly he had poor diabetes control. And the nurses were saying, hey, you can do it before. Why aren't you do it again? And it's like, he's not interested. So they came and asked us, what's the problem? Why isn't he doing this? So we went to ask him, what matters to you? He said, look, I just got married. My wife is expecting our first child. I need to stabilize. I need my job to make sure I save money to stabilize the first. So he was saving a lot of money. Then what do you work as? Oh, I'm your ambulance driver. He drives ambulances for our hospital. And then we went in to look, and honestly, our ambulance department is very good. They provide coffee and biscuits for all their ambulance drivers because you never know when you're called to drive off and pick up somebody, right? So, what is the best way to get sacked as an ambulance driver? You get crashed, right? Why would someone crash? Hypoglycemia. So this young man was trying to keep his sugars high so that he will never ever get a hypoglycemia. And he was doing that on biscuits and coffee so that he could save money for his. So what was important to him? Family and his home, right? He is totally coherent. He is totally coherent. We were asking the wrong question. Why can't you do it now? Because right now, that's not the most important thing to me. Right now, the most important thing to me is my family and my home. Yeah. So the actual issue we should address is, can we find him a more stable job that doesn't depend on him having high sugars? Correct? Yeah, so if we don't understand what matters to people, we are going to diagnose the wrong thing and address the wrong issue. Yeah? Okay, enough stories. There are new things like, for example, right, can we partner with people? And people say, no, this is health problem. No. But determinants of health, social, environmental, behavioral, there are so many things affecting health, and we're not addressing any of this. If any of our partners would do this, benefits accrue to us. Why wouldn't we collaborate? We should. And we should get pronto, right? Change in hub to the home. And this is where I wanted to say earlier, which I said, stop our story, right? When a person has a low health need, okay, and is at home, who controls the outcomes? Is the patient and the family. The system has very little control. So when I send a person home with a prescription, and if he does not have money, he's going to buy half the amount, break his tablet into half, and say, I'm taking medicine, but only half. And he won't tell you that the problem is, I don't have money, I don't have a job. Yeah? Of course, if you break your arm, right, you will come into the system. High health needs, you need hospital care. The system will control the outcome. So we need to know who controls the outcome. So out in the community, we don't control the outcomes. So we better partner with the patient. That is really very important. And so we did the first thing is, we took the frequent flyers, tip of the pyramid, 400 patients who spent 9,000 bed days in 6 months. And we went to find out what happened to them. Yeah, you can look at the YouTube that we did, and we came up with the first program, which is called Aging in Place, and we put a value proposition there that if patients were well cared for after hospitalization, then their health conditions will improve, and they will adhere to their care plan. Okay, they need not go in and out of hospital spending that much money, and their quality of life improves. The hypothesis then we said was actually their unmet needs, and we don't even know what the unmet needs. If we can meet these needs, they will remain well, have better quality, reduce their expenditure, and maybe be confident even to die at home. So with that, we basically had a logic model, the usual thing that everybody does, right? To try and come up with this. So with this one single idea and purpose, we got a little bit of funding. We started small, okay? And This is the story of Mr. S, who was one of our patients whom we studied. He has diabetes, but he's the one who looks after the house. He does all the housework. So he cleans the house, everything. And one day, while he was cleaning his house, he knocked over a glass vase. One of the shards cut into his leg. Within a week, it was amputated because he had diabetes. Yeah. Okay, means wheelchair. Not the end of the world yet. When we went to visit him, okay, we thought he'd be. No, he's cleaning the house and he's doing heavy laundry. This is a guy with great passion for life, right? And then he was still having a good quality of life because his wife would push him and go everywhere. They even went to Mecca together. And then his wife died suddenly. Bled from a stomach cancer. Devastated. Depressed. Didn't eat medicine. Came into the hospital. Became a frequent flyer. Okay? And he said, if I can just do it on my own, I want to do it myself. I don't depend on my children. I want to be independent outdoors. Okay? And he has a potential. Did we hear him? Okay, so we had to go and investigate. This is what we found. This is the pavement to his house. This is a very young, strong occupational therapist trying to maneuver that pavement up to his house. At his age, 80 plus, he couldn't do this. If we didn't do the home visit, we wouldn't have known. Yeah, so we went to his house. Not only that, this is a 15 centimeter drop. If you are a wheelchair user, you will know that coming out of a door, you want to do it backwards. To drop 15 centimeters down, ouch, you're going to hurt your back. So he's a prisoner in his own house. So the first thing we did was we got HDB East, put in a ramp. The therapist said, wheelchair is really bad shape, buy a new one. And then she thought, hey, how about we bring him a motorized scooter? And because he couldn't see well, he was diabetic, she put all those extra red tabs to say, this is the horn, this is the brake, this is the right. She did that. And then she taught him how to transfer to scooter, get out of the house, get into the lift, cross the pavement, cross the road, round the corner, come to where his favorite daytime place is, which was a day center. Okay? After that, he will go marketing, shopping, go home, see the same path to his house. Now he's getting in and out. Not only that, this man said, right, hello, town council, this kind of thing, right? You cannot let this thing happen, no? People like us, they're going to trip over. At age 85, he was advocating for people with disability. This is what freedom can happen, can give people. Yeah. So this is one story out of so many. And we won't know until we see this. Yeah. And the only indication we had was not measurements. Unfortunately, we didn't know how to measure this. But we went and submitted to public service. They gave us an award. Then they nominated us for United Nations Public Service. And then they gave us this award. And it's like, okay, we're on the right track. Yeah. That gave us the confidence to do more. Yeah. But, you know, right? You can do this, right? It will still not solve the problem because they do not have community support. So we said, we have to build a regional health system of support. Okay? I'm a very simple person. We only need 3 things, right? So I draw institution, community. Today's problem, tomorrow's problem, and then I have 4 sections, right? And I say, hospital, if people come in, we need to get them out quickly. But if they don't need to come out, can we keep them out? And if they come in, can we discharge them safely back to community support? Just 3 ideas. Okay? I'm just going to go this quickly. Right? So our Aging in Place program is basically about discharging them safely to home. But not all go to home. Some of them go to nursing home. So we did have a subsequent draw out the map out the everything, and then now there's a full ecosystem to help people living in nursing home to also get out of hospital quickly with good care, right? And then now tomorrow's problem, okay? How do we keep people out in the community? Yeah. So this is what we're very used to. We are the specialist team. Patient comes to us because GP refers the patient to us, and then we are so good to the patient, they like us so much, they don't want to get out of the hospital, and then the poor GP no more business. So we knew this very well. This was working for us, and we said, hang on there. Why do they have to come to see us? Can we not partner with the GPs, right? So we started by putting a nurse out there. And we said the nurse can talk to the GP and the patient. Okay? Then we said, how about the patient goes to his neighborhood? What Clayton Christensen called a facilitated network. Yeah? And then we thought, oh, some of these don't need a nurse to do it, right? How about we have a connector? We train a non-healthcare person to do this. So with this all, right, we bring the patient into the community, right? And we actually create a supported self-management system, okay? And that is in the community and in his own home, okay? Anything he can call his community, he can call the connector, he can call the nurse, or he can call the GP. He has so many options now. Instead of, I need to go and talk to my specialist who has long waiting lists, by the way, okay? Yeah, and that came very nicely because then in 2018, the ministry started to talk about the three beyonds, right? Beyond healthcare to health, beyond hospital to community, and beyond quality to value. And then more. Now we have Age Well SG, Healthier SG, we have Action Plan for Successive Aging, 2015. We helped to do that. Okay, and it was upgraded in 2023. We really are doing quite a lot for our Singaporeans, and yeah. But where is all this happening? We say in the community, where is it happening? It's happening at the 3 wellness kampong, 23 community health posts, and some share posts. So these were just things that we do. Okay, it doesn't have to be these things, but these are the 39 community nodes. These are spaces where people, you come to share a pot, which is a frailty prevention program, okay? And if you have pain in your knee, you can just ask to see the nurse. If you come to Wellness Kampong, you're doing calligraphy and you've got headache, you can ask the community nurse, right? If you are at the community health post, you can learn how to check your own blood pressure. You can learn how to check your own sugar. You can learn how to do caregiver in the community. You don't even have to enter the system. This is what we call forward defense. Yeah, and that is what we built in Yishun. So we started with that, 2014, 2015. Today, we have 39 nodes. 3 of the black boxes, they are called Wellness Kampong, and the rest are community health posts and share pots. So these nodes are really what we call bumping spaces for people, right? Where you can meet a neighbor. You could have been walking past them for the past 20 years. And then now finally, hey, now I know you're in this block at this, but you want to go together down to the center. So they're now talking, and they're now doing things together, supporting each other, okay? And this was our mapping in 2022 near the end of COVID. All right, we had 38 community projects, 21 nodes. I can't remember. We have to add up those numbers, but that I think it's about 7,000 something. All right, and then today, we literally have more than 10,000 people whom we know are actively engaged with us in the community. Yeah, and that's where we do our, yeah. So you can read more about it there. There's, you just, I think they did the QR code somewhere.
That's what I was saying.
Yeah.
So we have the QR code.
Yeah, yeah. And if you really want the hard copy. I brought 10 copies. So you, no, okay. I made it a point not to sign because it is not totally my work. It's actually a whole lot of people's work. So you will see this book has got the thinking behind it in the first part, okay, and the actual people in the community telling their stories. And I think that is even more important, yeah. And in end of last year, we updated it. We now have 78 projects. So it's just growing, yeah. We want to see that growing and growing, yeah. Okay, so I'm finishing. You will read about what is our ethos in building this, okay. And really the idea is that when we first started, we only knew how to do this, right? When people had a problem, they left it unattended until it became a crisis, and then the people come, right? And then we said, okay, what are your needs? So we do a needs analysis and we design services to help you cope. So they became a coping community. Then we asked, can we do something earlier? So okay, we identified the problem earlier and we do early problem solving and we teach them how to self-manage so that they can be independent. So they became sufficient. They didn't need us a lot. Yeah. Can we go even further? But there's no problem. What to solve? So our start point changed and the conversation changed, totally changed. The conversation was not about health and problems. The conversation was, what can I do? What are my strengths? What is my capacity to care? And they started to bring their dreams to the conversation. I want my community to be thriving. I want my community to support vulnerable people. So I'm not saying this is important, this is not. We need them all. Okay, but these two pieces of work are what we call a long-term build. I won't see anything in 2 years. 10 years, maybe, it's more than 10 years already. We're only starting to see this. So it's a capacity building approach, okay? It's place-based, it has to be local. This will not work in Bedok, this is Yishun. The method may be used, but you have to walk the ground. If you live in Bedok, you live in Whampoa, you have to walk the ground to know what is the culture of the people there. And then you need to work with them about what they want for their communities, which is not Yishun. Now, by the way, Yishun is called the other country. You all know, right? We kill cats. Yeah, apparently there are a lot of horror stories, there are ghosts, and there are a lot of things. So when they want to test something unpopular, they will go to the other country. Once they've tested it, they'll bring it back and they say, okay, it's tested. Right? So yeah, horrors. Nobody wants to replicate Yishun elsewhere, but yeah, it's okay. Yeah. And the last thing is, we always say, right, if you want to build a community, do not go in and be a hero. Yeah, so we took the Bertzop model of Holland, okay, where they actually have this, they call it the onion model of care, where if I have a problem, the first question anyone will ask me is, so Swifan, what are you going to do about it? And the next question they will ask me, who have you asked? Your family? Your friends? Your neighbors? Your community? Have you asked them? Then only we will ask, oh, so you're quite exhausted. You tried quite a lot of things already. Now what can I do to help you? So we stay in the third question space. Yeah. Before we bring the whole system behind us. Yeah. So that community problems stay in the community and are solved by the community. And in truth, in Singapore, they are actually very strong. Many people are waiting to be asked. Yeah. But we have a very strong service culture, so we tend to, you got problem, stand aside everybody, I'm the expert, let me help. I'm saying stand back, watch. Yeah, that is what will do well for us. Yeah, and yeah, thank you. So that's my work. Have I got time? Yeah. So I thought um, honestly I'm not so good at answering things like, what is the impact of my work? But I'm here to open my brain to people. So if you want to ask any questions, I'm happy to try and answer them. Yeah. But I do have some questions if you don't have. And some of these questions are really, okay, right? Um, do I want to live in a Singapore where my role, my choice, and my citizenship is secondary to those assuming authority, right? Which means doctors, okay, police, lawyers. Do we want to live in a democracy or a technocracy? Because if we want to build a country of very high level professionals, everyone is a professional, we're all going to come and get each other. One day when we are old, when I'm old, the doctor is going to say, I need a nursing home. And I'm saying, no, 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 drop me into the library, please. I want to stay in the library for daycare. And he says, no, you're going to a nursing home. That's technocracy for us. If we continue to build experts and experts and experts and experts and not look at community for its strengths, we're going to be ruled by the same technocracy that we built. So we might want to think about that. Yeah. Yeah. And I want to bring back Lynette's point and Uli's point about person-centeredness. And that in this world, when we're doing a lot of digital work and things become a lot more distant, mattering matters. What's mattering? Mattering is about seeing people for who they are, right? There are 4 things in mattering. Right? One is attention. I am seen, I am heard, I am noticed. Okay? The second thing is importance. I matter to other people. Okay, so I'm valued and I'm valuable. Okay? The third one, sorry, I got to look at my notes. I just learned this one. Dependence. What I do actually matters to everybody. Maybe not now. I hope at least 10 years later. At least when my daughter asks the question, when I'm in the grave, I don't roll right, she would probably say, what the heck was my mother thinking at that time? She had a chance and she didn't do it. I don't want that to happen. And the last thing is what they call ego extension, that others are proud of what I do, that my daughter would be proud of what I do today. Yes, that is about mattering, seeing people. And that's what we are about. That's important to me. Yeah. So I'm going to end here and let you ask questions. Okay, sorry.